He's currently the Senior Medical Director and Co-Executive Director of Kaiser Permanente's Care Management Institute. But he was invited here today mostly because he very recently was the former Director of Health Information Technology for the Agency for Healthcare Research and Quality, otherwise known as AHRQ. Prior to joining AHRQ, he was Senior Clinical Advisor in CMS, Center for Medicare and Medicaid Services. He was instrumental in the design and implementation of quality and safety programs there. And previously, he's been at the Utah Healthcare Institute, where he was Executive Vice President. He's also a founding member of the Intermountain Healthcare's Utah Valley Family Practice Residency. And in both of these capacities, he crafted and established community outreach and public policy programs really aimed at care for the underserved. He received his MD from the University of Oklahoma. Boo. And, oh, excuse me? That just came out. We're playing immune. Go immune. Anyway, and he completed his training at the Fairfax Family Practice Residency. He's board certified in family medicine, and he's a fellow of the American Academy of Family Physicians, and he's also a former Robert Wood Johnson Health Policy Fellow in 0102, where he worked for Senator Bingaman from New Mexico. So I've known Scott for a long time. He's a good friend of mine and Chris, and we're delighted to have him here in Missouri to kick off the Health IT afternoon. So welcome, Dr. Young.
Thank you, and good afternoon. It's really hard to follow that noon lecture. Now, I want to tell you, I was looking at my plate and looking at my dessert and looking at those slides and listening to this and trying to be mindful. But I don't know about you, but I have to admit, just to everyone here, I did have a little of the chocolate cake. I had a small, not the whole thing, but I had part of it. I left D.C. and now I live in Berkeley, California, and work for Kaiser Permanente. And in Berkeley, in fact, tofu has been moved in as a food group. We now have just made the whole switch on that. So is this where I launch the missiles at when I push? Which button is it? The one on the right? Okay, here we go. Well, listen, today I want to talk to you just a little bit about health information technology, and I want to look at it from a lot of different perspectives. I'm a family practice doctor, and I think I still identify with these problems as a family practice doctor. I really think, what does this look like at the point of service, at the point of care, and how do these systems roll up around that? And so you'll see a lot of that blended in. At the same time, I've spent a good portion of my life working for a major purchaser of healthcare services, the Centers for Medicare and Medicaid Services. So I'm cognizant of that, and working for major providers, and also thinking about it from the state level. Certainly we did that in Utah when we passed the Utah Telehealth Act and did some of the work around the Utah Health Information Network. So you'll see a lot of that blended into this. But more importantly, I wanted to give you a sense for how some of the federal and national policymakers really kind of think through these initiatives and issues. And finally, we'll have a series of what I think are some of the compelling issues for you to consider in your work later on this afternoon and into the weeks, months, and years to come. This is a call to action from the IOM in 2003 from their safety report. Americans should be able to count on and receive health care that is safe. This requires, first, a commitment by all stakeholders to a culture of safety, and second, improved information systems. I really want to point out that the second part of that is information systems. They don't really do much without a commitment to use them and integrate them. Again, this is going to be our afternoon. Some drivers, the potential of health IT, some of the challenges, and the current efforts both in the state and federal level. Let's just start out with the changing practice. Everybody knows this guy, or most people should know this guy, Marcus Welby. Marcus Welby saw one patient every week, right? he made a really good living doing this. And he had a ranch house, he had a partner, I think he had, somebody to take care of his house. This is kind of before global payment systems. I will tell you that. I think, I'm still trying to figure out how he did that. But obviously it has changed. It's gotten much more active. This is kind of what it looks like these days. And I think a lot of folks have seen this place. A lot of primary care providers have seen this patient. This is a 58-year-old gentleman who's in your practice who comes in for a routine appointment. He said he's a little woozy and kind of dizzy after his consultation with a cardiologist, and that was following his MI. And that's the first time you've heard about both of those events happening. And he's now sitting in your office. And you check his blood pressure, and it's a little low, and his pulse is maybe a little low, and you have no idea what happened to him. You have no idea what medications he's supposed to be on, and you have no idea what to do next, at this moment in time. And so, kind of what's the next steps? Well, it all depends upon who you are in the middle of this thing. If you're the patient, you're kind of wanting to know what are your treatment and diagnostic options. I mean, kind of how do I take care of this? What's the best follow-up? Should I be with my primary care doctor? Should I be seeing a cardiologist? Should I be seeing somebody else? Should I ideally be seeing a team? What's the evidence-based care? What's the best evidence for taking care of me? Who should coordinate this? And maybe kind of other concerns. For providers, it's very similar, clinical decision support. What do I do with a patient who's post-MI, who's now, dizzy, a little hypotensive? What should I do? What's the pertinent past medical history, current meds, et cetera? How do I get that? What are the allergies? And, potentially procedures, radiology, and lab. And kind of finally, what was the care plan that happened with that patient? Now, keeping in mind, when I see a patient in a primary care setting, it's usually a 7 to 10, maybe if I'm generous, a 12-minute time corridor that I have to make all these decisions. And that information has to be there at that period in time. And if it's not there at that period in time, it's inefficient both for me, it's inefficient for the patient, and it really leads to fairly poor decision making. I don't think any of this is a mystery to anybody in this room. So here's how we gather that information now. We pass out the clipboards to everybody, right? So it's self-generated reporting. We try and get it faxed in, and everybody knows what those faxes look like, with little numbers that you can't hardly read. There's snail mail, of course. The occasional phone call with a provider, or with a care setting, and of course patient-generated care. Now this has led to 1/3 of Americans currently maintain a personal medical record just for this. And Carolyn Clancy, who I used to work for, our husband actually disbelieved this number. And she pointed out to him, she said, "Honey, do you know that big manila folder that you have downstairs with the rubber band around it?" And he said, "Yeah." I said, "That's a personal medical record. It's not a real fancy, little IT thing." And this is what most Americans, or 1/3 of Americans, are using right now, to really kind of try, has a workaround for a system that doesn't adequately share information from one care setting to another. So that's kind of I just kind of want to put that out there has a really level setting. This is one example in one care setting in one day, and it's probably happening in this town right now in multiple places. Let's talk about some drivers for change, some of the things that we see nationally. There's double-digit increases in insurance premiums and underlying health inflation underneath that. Actually, this year we got down to a single-digit increase, which was remarkable. But, medical inflation continues to outpace common inflation by anywhere from 4 to 7 percentage points a year, and it's been pretty steady on that. Purchases are just unable to measure or account for the quality of care. They're increasingly calling for systems to be able to measure this, and they really want it measured at the provider level. Small percentage of patients are increasingly accounting for a large proportion of care. At Kaiser Permanente, we generate about $35 billion worth of revenues a year. 1% of patients account for 1/3 of our medical expenditures. We have about 8.5, almost 9 million members. So that's around 85,000 individuals annually account for a little over $10 billion in cost. to show you just what that looks like. And people know who these folks are. I mean, they're, neonates, trauma, cancer patients, but an increasing proportion of these individuals are individuals with multiple chronic conditions. Very, very, very complex patients, which we need information and decision support to take care of. Again, dramatic increases in chronic disease, and long-term care costs are increasingly rising. So these are the things on the horizon that certainly what we see purchasers and providers talking about. Again, the disconnect, costs go up and annualized about 8% last year. Quality, has reported by the National Healthcare Quality Report, increased about 2.8%. So there's a disconnect. The kind of the volume of medical knowledge that's hitting us now is really staggering. It takes about 17 years between discovery of basic innovations in medicine and actually widespread adoption. That's been a stable number since the early 60s. Really hasn't changed much. And it's just a tremendous output that we're seeing in our research dollars. A couple of recent examples. There was an article about a week and a half ago which disputed the notion of reducing LDL cholesterol to less than 100 in patients with cardiovascular disease. Now, we spend billions of dollars every year reducing people's LDL to below 100. It's a non-trivial number that we do this on. And now we're kind of going, is that the right thing to do? Is it the wrong thing to do? How long is it going to take that to kind of get out, into the mainstream? As well, just I think yesterday, the day before, there was an article, actually I read it first, embarrassingly enough, in USA Today, that came out in the New England Journal of Medicine that said that, CT scans, screening for patient smokers with for lung cancer, it actually showed some remarkable improvements in survival. So, I mean, how long does it take that to hit mainstream medicine? Well, a colleague of ours, a fellow named Andy Bayless, did some work, and Andy said, here's the diffusion of knowledge curve, and here's what it looks like on the front line. Flu vaccine, the landmark trials in 1968 and in 2000, 2 out of 3 people who should get a flu vaccine did get a flu vaccine. Pneumococcal vaccine, 1977, 1 out of 2. We're a little better with mammograms. 3 out of 4 women who should get a mammogram do get a mammogram. The actual landmark trials in 82 and 84 cholesterol screening, about 2 out of 3 people who should get it do get it. This is not because clinicians don't want to do this or think it's a bad reason, or really are arguing. It's because the clinical decision support, the kinds of reminders that they need to hit at that, remember that corridor in time, that few minutes you're spending with a patient, you need to know, is this the right thing to do? Is it automatic, and is it easy for me to order this? And it's not in today's medical culture. Let me go through this quickly. The National Health Care Quality Report findings. We saw some modest increases in quality from year to year. It's variable. Patient safety improvements mostly at about 10%, but overall improvements in quality are only annualizing around 2% per year. The good news is it didn't go down. And some disparities are diminishing as well. Racial disparities are growing smaller than larger for 60% of our quality core measures and 100% of our access measures. So this is good news. We think Health IT can impact this as well. Again, keeping in mind that these are the things that we want you to see as it has the spectrum of issues that federal policymakers are actually looking at when they make decisions around health information technology spends. So Health IT also has impacts on the variability of care. This is some work that Wenberg did, this is his 92 study, on the variability of coronary angiography across the United States. Now, don't necessarily pay attention to the numbers that are over from the legend in the lower left corner, but just look at the color variations across the United States. It looks like a fall leaf pattern. Right now, I mean, I'll tell you, as a clinician, that an atheromatous plaque in a human being is an atheromatous plaque in a human being. It does not change between California and Florida. And so having variations in care is inherently inefficient, and some people would say it leads to lower quality care and some safety issues as well. And so we have to do better at this. But first, we need to be able to at least know what we're standardizing care for. What does it look like from point A to point B? At Kaiser Permanente, this is something that we struggle with. Actually, variations in care. How do we get the same care for a patient in the mid-Atlantic states that we get for somebody in Hawaii? How hazardous is health care? This is a tongue-in-cheek look. So dangerous activities have more than one fatality per 1,000 encounters. Ultra-safe activities have less than one fatality per 100,000 encounters. It's logarithmic. And it actually is put together by a European researcher that we've used for a while. Flying on a scheduled airline, being on a European railroad, and standing next to a nuclear reactor are considered ultra-safe activities. You know, bungee jumping, climbing a mountain, and having an interaction with a healthcare system would be considered by this thing to be an unsafe activity. So I'll let you read into that whatever you want to. Finally, you know, doctors are actually speaking out about the overwhelming amounts of information and potentially poor decision making that's occurring within the inpatient environment as well. This was the Time magazine from May 1st of this year. Even insiders can suffer, is what one of the authors was saying, and calling for a need to fix the system for everyone. Let's talk about the potential for health information technology. First, a few quick definitions. Health IT is a very broad term that goes all the way from health information exchange, switching information from point A to point B, to actually electronic prescribing, to other capacities, to more rudimentary electronic health records. Health information exchange is really what we talk about. Sometimes we refer to these as regional health information organizations. Again, the ability to share information between care settings, and that could be between providers. It could be between payers. It can be between, you know, other intermediaries. Sometimes health information exchange occurs between, believe it or not, the patient and the provider. And many times. Regional health information organizations, we're going to talk about those a little bit later, but those are fairly new phenomenon that are popping up across the country, usually at the state level. Electronic health records are what we would consider kind of the usual or kind of garden variety health information technology. This is doctor's in an office, opens up his computer screen, and you know, presto changeo, his paper records are now electronic. Computerized physician order entry, just that. You know, instead of writing an order down and having it transcribed manually, the physician actually orders it automatically into a computerized system. And finally, and I think the last one is one of the most important, electronic clinical decision support. This is, I'm sitting there, I have a diagnostic or a therapeutic dilemma that's facing me, and what modalities do I have to help me sift through, remember, all that information that's coming to play in healthcare, and help me think through or advise me on the best decisions. This is also the kind of alerts that help us around drug-drug interactions, those sorts of things. So electronic decision support is the toughest nut to crack within all this, but I think is the one that has the most potential. All right. I swear to God I'm pushing the button. Okay. All right. Who benefits from these? You know, it's really everybody, and everybody benefits in a different way, we believe. We'll talk about this a little later on. Patients benefit from health IT in a way of access and cost and being able to be an actual, you know, functional member in their care and understanding about their care. You know, we're now starting to see after-visit summaries that can be actually generated from interactions with providers who use electronic health records and health information technology that improve compliance rates and actual outcomes on patients just from generating these after-visit summaries and reminders. Purchasers, certainly purchasers are at the forefront and the vanguard of pushing for health information technology for good reason. They've done the numbers, and they know that they get better care for their employees or their charges, as well as more efficient care. State governments are more and more viewing health information technology as a win, particularly for their Medicaid populations and their SCHIP populations. The federal government government, we'll talk about that a little later. Providers, we've seen measurable improvements in clinical efficiency and provider satisfaction from the use of information technology. So really a tremendous potential, but it's largely unrealized. We only see about a 10 or a 12% penetration at the primary care level of electronic health records, but overwhelming evidence. Okay. And let's talk about that evidence today. To date, we've got well-demonstrated improvements with health IT with safety, in particular with medication adherence and the ability to interchange or know what a patient's lab results were. Very quantifiable improvements in care. Quality improvement as well, and that particularly lies around adherence to guidelines. And finally, we've seen demonstrated improvements around provider performance, optimizing providers' time, and that is almost exclusively in the domain of decision support capacity with health information technology. The unknowns are the big ones. One of them is actual productivity. Provider performance is one thing. Actually, how well do you take care of a patient? Actually, can you see more patients during a day if you use electronic health records than if you didn't? We've got no evidence to date on that at all. It doesn't look like that you can turn up the engine to 110% just by plugging in electronic health records. Nothing there. And finally, not much evidence around cost. We formulated and modeled improvements around cost with health information technology, and big systems have seen this, but in smaller institutions, we've not seen that demonstrated. This is what the numbers look like. National adoption of outpatient computerized physician order entry would avoid 2.1 million preventable adverse drug events per year, a non-trivial amount. Inpatient CPOE would decrease serious medication errors by half. Would go away. Half of serious medication errors that we have right now in the hospital would go away with CPOE administration. And finally, we believe that health information exchange and interoperability between settings would, we talked about this a moment ago, improve physician decision-making at the point of care through complete information access. No arguments there. When I was at ARC, we actually funded a cost and benefit analysis of health information technology from our Southern California Evidence-Based Practice Center and found this. And let me just read this. Health IT improves quality of care in large healthcare organizations that create their own systems and devote substantial resources to those systems. HIT has the potential to enable dramatic transformation of healthcare safety, effectiveness, and efficiency. So what I want to point out there is it says large systems. It doesn't mean that it doesn't improve care in small systems, because the first question is, well, what about the 4, 5, 6 FTE family practice clinic or internal medicine clinic? What does it do for them? We think it might improve care. We have no evidence one way or another. There's just clinical trials were just not done, in those venues. We think health information exchange is a driver for health IT uptake, and it'll have an important but a somewhat limited impact. It has the potential and demonstrated efficiencies. If you're able to get information, we will see improvements. Patient-level data, unfortunately, in health information exchange may be available but not actionable. In other words, if Blue Cross Blue Shield says, we're going to allow you to know kind of all the prescribing, the labs that this patient has had done, or medications that they're on, that sort of thing, and let you have a static look at it, it's good knowledge, but it's not actionable knowledge. It's not plugged into a system of care. So HIE is important, but not necessarily sufficient. Further, we believe that Medicaid, SCHIP, and other state purchasing mechanisms will be able to serve as the leverage arms for that. Really, when you think about who are you going to exchange information with, are you going to exchange it with somebody in Florida, somebody in California? No, you're probably going to exchange it with somebody within your catchment area, kind of within your referral area. And most of the time, to make that actionable and actual leverage, that ends up to be a state border. There's some there are some areas where that doesn't necessarily pull true. St. Louis, I think, would probably be one of them. The Washington D.C. area are others, but by and large, most of the time, these are confined to state borders, and that's where we're starting to see the movement at. Benefits to Medicaid programs, efficient patient tracking, ADE prevention, chronic disease tracking and care management. I heard some of your discussions earlier about Medicaid. None of these are going to be a surprise to you at all. Implementation of evidence-based medicine, prevention and screening services. Finally, at the very bottom, effective public health monitoring. Being able to actually capture patient data real time will be increasingly important. When we, at ARC, we funded 122 projects in 43 states. Our projects really affected about 40 million Americans. So a fairly broad repertoire and spread of those programs. I thought it might be interesting for you to see why people actually applied for the grants and what they were trying to do with those grants. So what's driving health IT adoption nationally? And 85% of our grantees wanted to improve their health outcomes. That was the first thing that they wanted to do with this. 76%, 3 out of 4 wanted to reduce medical errors. Another 3 out of 4, improve inter-provider communications, workflow. Reduce cost of care, only 1 out of 2. So, and I actually, when we fielded this survey, I actually thought that would be higher. Because there had been a fair amount of talk at that time around health IT as being one of these hopes of reducing costs. But in fact, that's not why the preponderance of people wanted to install these systems. They wanted to do it to improve care of their patients. I would be remiss if I didn't talk about the Kaiser Permanente experience in the midst of all this. So Kaiser Permanente has instituted a few years ago a national health IT strategy, and really an electronic health record for all 8.5 Kaiser Permanente members. And we call it Health Connect. It's a derivative of a system called Epic, which is an electronic health record coming out of a company in Madison, Wisconsin. It's rolled out in all 8 regions, 9 states, all the way from the Mid-Atlantic area to Hawaii. We've already seen improvements in care. We've already seen measurable improvements in care as this thing has been rolled out. It's currently one of, and what we believe it's the largest civilian health IT project in the world. There's not really, a Guinness, metric on this. But as we kind of looked around, we can't find one bigger in the civilian world. And I'll tell you what that's led to is some significant experiences in cost, integration challenges, value realization, and workflow changes for us as we brought this on board on a system-wide level. And I'll give you a for instance on this. About 50% of our investment is on hardware and software, and about 50% of our investment is around soft costs. And those soft costs are clinicians come offline, reduce productivity, training, those sorts of things. So when people, and we learned this, when people actually say we're going to budget for X dollars and then put kind of a trivial amount, 10% on top of that to integrate health IT, we would say, it's times 2 to do it right. To do it and actually see value realization out of it, it's a times 2 number. That was something I don't think anybody had any kind of data about before. Remember, the systems that we had before this that we'd studied were legacy systems. They were built, homegrown. Some doc, and an IT person had really this was a labor of love. This is one of the first ones that's actually a commercial, off-the-shelf product that went into one of the largest healthcare providers in the world. And that was the experience. The other thing that we were able to do, and this is actually with some pride, and what we've seen has significant acceptance, is each Kaiser Permanente member has a personal health record. You can email your doctor. You can look at your health records. You can check your labs. You can do all that stuff. That was a big deal. The satisfaction that we've seen out of this, and people becoming self-activated in their care. Suddenly I'm a diabetic and I can go online and I can actually figure this out, or my daughter can help me go online or whatever, or I can get assistance in doing this. This is a big deal, and it's a major part of our strategy to move care into the home. To get it, the care that should be in the office should be in the office. But health IT is one of those major ways where we can shift it into the home. And we can actually start making people who are the real primary caregivers of the patients themselves. We can actually start enabling those people with these kind of technologies. So the personal health record, all 8.5 million Kaiser members have that now. So let's talk about the tough stuff, at this point. And I'm going to talk about some of these in more detail. Provider buy-in is just huge. If you don't have this, you might as well stop at this point. If providers say, this disrupts my workflow, I'm not going to, buy into this, you might as well stop. Provider buy-in actually has 3 phases of providers' lives. And what we found, younger providers and older providers are much more accepting of health IT. And if the younger providers are, I'm kind of just starting out in my career. I'm not malleable, but I'm kind of formidable, and kind of used to this. They like it. Older providers are, I'm really tired of this. It's been a mess. If I see one more fax or piece of paper on this, I'm just going to, throw up, and they're very accepting of it. People who are probably my age, who are in their, the sweet spot in productivity, who are really good at this, and I got my game down, and I'm just trying to, put my kids through college and all this kind of stuff. Don't give me anything that's going to blow up my life. And it kind of makes sense. And really thinking about it in those phases helps as well. Legal and regulatory issues, I'm going to talk about those in a minute on a separate slide, as well as the privacy ones. Financing remains a bugaboo. Who pays for this and who realizes the cost benefit? And it still remains to be 2 different groups. Providers and provider organizations continue to bear the burden of investment costs and implementation costs, and usually, as of today, don't have value realization from that unless they're in a system of care. And that system of care can either be real, bricks and mortar, Intermountain Healthcare, Geisinger, KP, or it can be virtual. But it has to be a system where you have that rolled up together. Organization challenges, workflow issues are paramount and will remain paramount. Information technology is inherently disruptive. It's always disruptive. Cell phones are disruptive. Doesn't mean they're bad. It just means they're disruptive. Who creates the standards and who says that and who's going to hold it to it will remain an issue into the future. Again, capitalization costs go into the financing. And finally, there is that big one, does it need to be within a system of care to be effective? And we haven't solved that one yet, and that's a perennial debate. Legal and privacy issues, there are a federal floor on privacy issues in our country. That's HIPAA, the civil rights legislation, the Federal Privacy Act, and some people would say the USA Patriot Act, sets a floor for privacy issues. Each state trumps those privacy standards, significantly. No one really knows what that looks like. So if you wanted to exchange data with Arkansas, or God forbid, Oklahoma, how would you know that you're not in violation of somebody's law by exchanging information? And you really don't at this point in time. Medicaid actually predates HIPAA and is actually a stringent privacy charge than HIPAA. So the legal and privacy realm remains as yet to be unexplored. Financing, we talked about. Initial capitalization costs are very high. We talked about a doubling of the hardware and software costs. And again, no direct linkage, and I can't overemphasize that, between initial investments and revenue or value realizations. So at ARC, we tried to do a little work on this. We have all of our savings models to date that we have up to the last couple of years ago were models. We were asking people to make potentially, in Kaiser's case, it was over a $4 billion investment based on a model. And that's the kind of I mean, we think it was a good investment, but that's the kind of investments people are being asked to make more proportionally based on that. We have studies in the field. We're actually starting to see some positive ROI at the state level and actually with health information exchange out of some of our initial studies. More on that in the next 12 months. One of the takeaways on this is that any benefit will require a provider participation, and probably where we'll see ROI in the future on health information exchange will be around pay-for-performance programs or pay-for-quality programs or other participatory issues which require health information exchange, but not necessarily pay for health information exchange or health information technology in and of itself. Finally, the ROI without that can be very long, up to 5 years. Let me tell you a little bit about the current efforts, and then I'll close. There was a recent executive order on transparency in healthcare, and I've just got a couple of punchlines out of that. One of them was to ensure, as the sections, ensure healthcare programs administered or sponsored by the federal government promote quality and efficient delivery of healthcare through the use of information technology, or the other parts to it. There was a transparency component as well as others. But this is a requirement for federal programs by January 1st of 2007. So people back in Washington are working really hard trying to make that happen at this very time. And that's Medicare programs as well as others. So there is one program that was held back and not held under this clause, and that was Medicaid. Medicaid and S-chip programs are not required to the same test as other federal programs. So right now we have I guess 20 or 30 regional and state health information efforts emerging across the country. These go very widely in scope and actual complexity, all the way from the Indiana Health Information Exchange, which was very complex, well-standing program to exchange information at the emergency room level, to one I was involved in Utah, the Utah Health Information Network, which we actually serve as an electronic post office, if you will, where any entity or any entities that want to exchange health information, electronic health information can. We don't open the mail. We don't open the mail, but we have, for a small fee, allowed entities to participate in that. I will tell you the ROI around the Utah program. One of our insurers, the first year of the program, there was an upfront investment of $25,000 per entity. They realized a seven-figure return the first year off that $25,000 investment on health information exchange. So RIOs and HIE efforts at the state level are returning, in some instances, when they're done correctly, non-trivial amounts of return. Again, they're too numerous to count. There is over, what we believe, over 100 regional health information organizations across the country, and I want to really kind of reserve that number that you hear, hundreds of RIOs popping up across the United States, from ones that we recognize at AHRQ. At AHRQ, we would only recognize a RIO if it had a state government at the table. I mean, we had to see a preponderance of players, a critical mass of players at the table to recognize that. And that got us down to, I think we were 20 at our last count. What is Regional Health Information Exchange? A collection of individuals and entities sharing patient level data. We first identified these, or called them these, during the Federal Health IT Strategic Framework. And many had existed for years. Obviously, Utah, we were in the mid-'90s when we put that together. What's exciting now about these RIOs, and I hope you're having this discussion here in Missouri, is that a lot of them are being actually codified in state legislation. And actually seeing support from that. I think that's an exciting change. There's an unclear standing with national and federal purchasers and regulators, although I think in the next couple of years, particularly with what we saw in the executive order, that will change. I talked about this a moment ago. This is what's going on at ARC. Our initiatives in 43 states are about 40 million Americans which were affected by those. Let me tell you about our Rio investments really quickly. At ARC, we invested in six 5-year state-based contracts to exchange two kinds of information: medication data and lab data. These were contracts. They were for $1 million a year. And Ned knows Colorado actually was participating in this and actually trying to figure out, what's it look like to exchange pediatric level data. I mean, what are the particular challenges around exchanging information where the individual is not necessarily has a proxy for giving them permission to exchange that data. Delaware is built mostly on the Utah project. Indiana is the Indiana Health Information Exchange, kind of on steroids. Rhode Island is actually figuring out what does a master patient index look like around health information exchange, and it's interesting. So we don't have necessarily unique patient identifiers in this country. And so to figure out that you are you, I have to use a probabilistic algorithm to do that. That there's not a bunch of Scott S. Youngs out there, and we're not kind of willy-nilly exchanging and mixing that data together. And so Rhode Island took that on and actually kind of go out and test those models. And this was no small thing. I mean, the ACLU was camped outside their door, for the first 6 months of this program, and they took it on, and they did it in a very transparent way. Tennessee is looking at the challenges of, and you'll love this, of publicly funded programs. And Tennessee actually have a TennCare program, brought it on. When we funded them, TennCare just about went into receivership about 2 weeks after we funded this program, and are doing well at this point. Our Medicaid initiatives, which I think will be of interest to you, at ARC, we're actually funding a project to help define what the state privacy laws look like. You ought to see results of that coming out later on this year or early in 2007. It's actually a survey across the country. We've done a couple of Medicaid health IT summits, actually trying to figure out, what is the best purchasing position or the best participatory position for Medicaid. A couple of brief reports on health IT and Medicaid, and those are all available on the ARC website. And I just wanted to give you a little heads up on that. That's www.healthit.arc.gov. At ARC, we created the National Resource Center for Health IT. In that resource center, we have over 5,000 unique data products around health IT to help people figure out the right way to install and integrate health IT. This is what it looks like. It's searchable, for a wide variety of issues that you may come across, all the way from funding issues to the policy issues to I'm putting in an electronic prescribing system in my clinic next week. What are the things I need to do? I mean, it's got that level of data in it. So I commend you to the NRC website. The Centers for Medicare and Medicaid Services have remained in this game, and they actually created a specific office dedicated to health IT efforts. The Medicare Modernization Act had two really critical components. One of them was the stark anti-kickback rules, which are now not only underway but are out, and actually stipulate very specifically that hospitals can donate electronic health records and health IT technologies to physicians' offices. This is a significant change from before. And the chronic care demonstration programs are out. The Centers for Medicare and State Operations, CMSO, is currently exploring ways that the Medicaid information system can be used to help jumpstart efforts in your state. Finally, the QIO programs in your state has a performance metric improving adoption up to 5%, and up to 5% of primary care offices as part of their 8th scope of work. The National Coordinator for Health IT, we have an interim national coordinator named. It's Rob Kolodner. Rob came from the Veterans Administration. There's been significant outreach at the state level, principally through the governors and through the National Governors Association, to some degree one-on-one with governors, but mostly through the NGA. The National Coordinator's Office was instrumental in some of the Katrina efforts, and finally, many of the efforts of theirs reflect something called the American Health Information Community, which is a FACA committee created by Secretary Leavitt around health IT. All right, a couple other slides and we'll be done. Let me just tell you what I think are wow. And this is the bad thing that happens with health IT. Okay. Technology always makes me nervous. You know, one of my woman named Sarah Rosenbaum, who's at the George Washington University School of Medicine, said, you know, we were talking about the difference between, you know, what happens on privacy issues with health IT. And she said, you know, if a doctor kind of loses a medical record or takes it home, or, you know, something happens with a individual's medical record and a paper record, it's you know, it's a lawsuit, it's a bad thing, you know, they may get sanctioned and stuff like that. You know, if they lose their entire, grouping of electronic health records, it's a class action lawsuit, you know, at that point. So, you know, so it's one thing about health IT. When it goes bad, you know, when it's good, it's good. When it goes bad in a big way. So, so these are as I was putting this together, I thought, kind of, what are the issues that I would think that if it was me, that I would be thinking about, you know, from your perspective. And here's what they are. You know, I would really be thinking about what are the drivers that need to be in place to push provider adoption and utilization of health IT, and those are two separate things. I mean, you know, what is it going to take at the state level, incentives, either fiscal or non-fiscal, to get providers to put this stuff in their office and then to start using it over and over and over again? And I think that is actually, you know, a state level issue. Is it standalone? I mean, do you say, Doc, you know, if you put in this software program, we're going to give you, you know, this little one-time bonus, or do you fold it in to larger performance programs? The physician group practice demo from CMS actually said that we would do gain sharing on large group practices if you improved broadly the care of Medicare beneficiaries with chronic diseases. Now, and we had a host of metrics around this, and they were significant gain sharing that came within this. It was split about in half. Now, you know, Medicare didn't say that you had to use health IT to get to those improvements. You know, and you know, when you looked at it, you couldn't get there any other way. I mean, but Medicare said, if you use pixie dust and get there, we're fine. You know, we pay you the same, you know, if you can get there. You know, so this is really kind of the question. Is it pay for click, or is it pay for something else that are going to get there? And that's, I think, a significant question. You know, what is finally the role of state government in supporting health IT adoption? You know, bystander? You know, enabler, you know, partner with other major purchasers as a regulator? I think those are significant questions. What are going to be your state's, you know, policies around electronic collection and distribution of information? This is the one thing that used to keep me up at night in the health IT portfolio, and it really was, you know, if we have one privacy blow up in the midst of all this, the game's over. You know, it's done at this point. So I think, you know, what are kind of the level of tolerances, you know, in the Missouri population around this? And that's a significant question. Again, what are the state alignments of federal, state, and commercial standards? You know, I think that's a discrete discussion that needs to be had. Private efforts or efforts that are underway that are singular may not actually be enough. So I would encourage you to align with the federal efforts. Finally, it's you know, it goes to the first one. What are the benefit realizations you're going to see from health IT at the state level? And I think, you know, finally, it's calling the question: do you want to use Medicaid, you know, as a leverage point to improve adoption of health IT? And I think those are discrete and real questions. So I'm leaving you, I think, with more questions I answered, and I thank you for that. And you guys, I look forward to hearing back from Karen on your proceedings. Thank you.
We've got just 5 minutes, so time for just a question or two from the audience. Dr. Parks? Here comes the microphone.
I was wondering about the role of third-party payers other than Medicaid in sharing information. There's a tremendous amount of clinical information in the claims data, and one often calls up to obtain an authorization, but one doesn't receive any information back in return about what medications, what other hospitalizations. Is there any movement to use paid claims data on the part of any of the big insurers to feed information back to coordinate care to the providers? Many patients see 10, 12 providers.
Yeah, there is actually in Tennessee. Shared Health has actually already started a program where they're kind of revealing data that they have and their claims data that you could search if you were an appropriate provider and had the appropriate securities. I think the real question with these, Aetna is kind of moving in the same direction as others. So yes, providers are seeing this has a market advantage. The real question is it's not tied into anything else. I mean that's what I said. Revealing this data is one thing, but it's not actionable. At the point of care, or it's difficult for it to be actionable at the point of care. So yes, lots of movement on this. And here's my worry: is that we're That's right. They're not going to look at it every visit. So I mean, the real question is, for you at the state level, is what is this going to look like in Missouri? Is this going to be, kind of a bunch of piecemeal, things, or it's going to be something more comprehensive, or is it going to be a federated system? I mean, anyway.
Your last slide got me thinking, and I guess I wanted to know in California how physicians who take Medicaid look at something like this. In Colorado, I could see this as being the straw that breaks the camel's back for primary care participation in Medicaid, which is already a poor reimburser in our state, and all they need is another reason to say, I'm not going to see Medicaid anymore.
I think you're right, and I think if it is kind of a traditional, we want you to make an investment, and then someday maybe kind of there's going to be some enhanced reimbursement that comes out of this, it's a non-starter. And it would be a non-starter for me, saying that as well. It's really the question is that here's one of these a major purchaser in the state, major market power, and the states are, and it could be from their state employees, Medicaid, S-chip, and how do we want to align performance payments around it? But I think if it's a you pay for it up front. Maybe someday in 5 years you get ROI, it's a non-starter. Yeah.
It seems to me, just listening to your discussion here, which I found to be very informative, thank you. This is a very complex system, and we're making efforts to disseminate it very widely across a broad range of practice. And as I listen to your comments, I come away with the idea that the proof of its efficacy in a lot of areas remains pretty questionable. Number one, can this be done outside of a captive system with a single set of physicians, a captive patient population, and a single payer? That seems a question. Kaiser, I think, is an ideal set up to bring something like this on board. It seems to me we need to invest a lot more time in these large groups that can fulfill that and identify where the gains really are before we start taking this out to community entities and say, you need to do this.
So I think at Kaiser it's a challenge, even in Kaiser. I mean, just to be certain that this didn't get turned on and everybody stood up and said, gosh, oh, wow, where were you yesterday? I mean, so it was a challenge there. I think the thought around, does this need to be within a system of care, is very good. I mean, that's where you certainly get the best realization. And, you know, health IT systems kind of force it. I mean, as you start bringing this in, you start linking groups together. You know, in this country, I mean, you know, we're not going to have a Kaiser or an Intermountain or a Geisinger everywhere. We're just not. Matter of fact, that's actually the minority of places that people get care in the United States, and probably will be for a while. So I guess the question is, what does a virtual, and this gets into health IT. The one thing I'll say about health IT is it always begets a larger question. And it's not about, you know, electrons, bricks and mortar health IT, but it's really about what does the system of care look like, and what does a virtual system of care look like, and how do we start putting those together? And I think that's going to be the real breakthrough. That's going to be the point where we start thinking about, how do I start paying for a group of providers who are loosely affiliated to provide care for a defined group of patients? You know, because they will have to share information. Remember I said about pixie dust? I mean, you know, at some point you can't get there any other way. And that's, I think, going to be the real driver, the game changer there. And I would actually look for that discussion to be happening in the next couple of years. I hope it does. It doesn't necessarily mean that we get rid of independence, but it just means that people join into a larger, I think, alliance.
To facilitate this integration, one thought might be if IT could be seen as an integrating force in the eyes of the Department of Justice in terms of negotiating with other entities, if that could be considered an integrated practice, that might be a greater impetus to bring physician groups together. Because they could integrate around IT, they could be an integrated entity, and instead of being one doctor negotiating against a behemoth insurance company, you now have an integrated facility that brings a lot more volume to the table to negotiate compensation. So if you're looking for a way to get that out, you know, you might try some different bait.
And I would tell you, I think that it's much better for patients. I mean, at the end of the day, you know, the kind of value realization that we've seen from having an integrated data system is you know, and quality and safety innovations is breathtaking to see. So at the end of the day, I think that I hope that we get to a win-win. So thank you.
Thank you. You guys who don't think about health IT every day are in for a treat. I know some of you do, but not all of you do. And when we come back, you're going to hear from some Missouri folks who are going to tell you about some exciting things going on in our own state today, right now, around some of these issues. So we're going to take till 2:15, so be back here in 12 minutes.